Some of it goes to how symptomatic the person is. Sometimes a drug can help the person become more accepting or able to focus on the psychotherapy. So sometimes you can use it just for a few weeks to calm them down and then move them on through psychotherapy. So there is nothing that says this is exactly how you have to do it. So psychotherapy or with a drug, either one. That very bottom part under non-pharmacologic therapy, it's just describing cognitive behavioral therapy. So since you've had it, I'm not going to walk through it. It just describes it. I'm not going to test you over it. It's just that since we used it a lot last year when I taught it, we didn't have any. I was the first one to mention it, so that's why it went in there first. Okay. On the next page, so severity of symptoms are going to drive a lot. If you can start with an SSRI, that's what you want to start with. If you need acute control of symptoms, you can use a benzodiazepine with it and titrate it off. Or if the patient prefers not to be on one, you've got those alternatives. So you can look at pregabalin or buspirone, hydroxyzine, just depending on patient preference. So you're going to look for symptom relief. You're going to look for tolerance of adverse effects. As the patient is on it, you're going to wait the 4 to 6 weeks to judge whether or not the patient is responsive. You're going to start with the low dose and titrate it up to effect. If they are depressed and have GAD, then you want to use an SSRI or an SNRI in the beginning. Page 12. Keep in mind mirtazapine, hydroxyzine also as alternatives along with your buspirone in the pregabalin. If they respond, the recommendation is to leave them on therapy for a year, for 12 months, and then reevaluate and titrate off. If someone doesn't respond to the first drug you choose, you can choose another drug in the same class, a different SSRI, or an SNRI, or you go to one of the more adjuncts, or mirtazapine if you need an antidepressant. Partial response, we talked about augmenting. We talked about tapering off benzodiazepines and the importance of that, what withdrawal symptoms are, likelihood of withdrawal symptoms occurring versus a short-acting versus a long-acting. All of those are the concepts, and that's what that walks you through. Questions? Yes. Yeah.
You start a patient on a drug and they're doing well, but they can't tolerate the side effects, so you change them to a different drug. Would you restart that 1 year period of how long they're on that drug?
I think so. I think you'd probably start that once you've got their symptoms under control, is you go that year. There's nothing hard and fast. Mostly it's telling you treat for a long period of time because what the person needs, they do need that some type of psychotherapy, because what they teach them is how to control those thoughts, how to control things that bring anxiety, how to judge how do your response. So having somebody work with them, and that I think is like a 3 to 4 months at least. So any kind of therapy you can get them in. It is hard to get people into CBT. There just aren't a lot. It's weekly visits. It's homework, and it is expensive. But any kind of psychotherapy they can get into that will help them, that's what you're buying with that year. I think also to help them see here's what more normal looks like. Sometimes they're situational, and so as the situation changes, then they're able to control their anxiety without. Does that help? So nothing gold about the year, but that's the recommended time. Panic disorders. Okay, so what do you know about panic disorders? Yes?
They don't have a trigger, they just kind of come on out of nowhere.
They just come out of nowhere, okay. What else?
Can be helped with therapy.
Can be helped with therapy.
Talk yourself out of it.
Say it again.
Talk yourself out of it.
talk yourself out. Okay, so the cognitive behavioral training helps a lot with that. What else? Have you ever witnessed one? One of my family members has one, and they are frightening. They're frightening to watch, or they are for one of my sisters has it, and it is really something to watch. So anyway, okay, so the goal is remission, no functional impairment, and bringing them back to normal, getting down the triggers, so substances that precipitate. Now this goes a little bit against what you've said, Stacy, but sometimes they do have triggers. They can, like my sister does have triggers. She can, if she can avoid those situations, she usually is less likely. Smoking, exercise, using CBT is thought to be very helpful. So the SSRIs, again, are the first line, and they're about 60 to 80% effective. Again, the same kind of time frame, so at least 4 weeks to see effect. Some patients don't respond in that time frame, but will continue to see improvement up to 3 months. The SNRIs, the venlafaxine is the extended release is the only one that has an approval for that. It's a little bit less than what you see at the SSRIs. So they're preferred, but the most commonly ones used are benzodiazepines because they're effective and they're very helpful. The same contraindications or poor candidates that we talked about for anxiety will fit here as well. So be careful in people that have history of drug or alcohol abuse. The ones that are most commonly used are alprazolam and clonazepam because they're very fast, especially alprazolam, very quick. But remember, that is the one that has some of the worst withdrawal symptoms. Seizures are likely if they are abruptly taken off. Let's see. The other problem with those short-acting, which is listed on the top of page 14, is that breakthroughs. They often have to be dosed multiple times a day. Alprazolam, you can dose up to 3 times a day. But it's very sedating, so a lot of people don't like to take it that often because they can't stay awake. But they also can get breakthroughs because it just won't last long enough. So there are extended release products, especially for alprazolam. Acute phase is resolution of the panic attacks, reduction anxiety, phobias, resuming usual activities up to 3 months. So keep that one in mind just a little bit longer. Therapy again for 12 months. If you start them on a benzodiazepine, have the plan to taper in the beginning. Seeing them frequently in the beginning is important so that you know response. The other is having them chart. There is a panic disorder severity scale that is out there, a validated tool. So having them chart their attacks, when they occur, how often they occur, level of distress impairment that went along with it may be of help to you when you are titrating or changing their dose. Okay, that's all I have to say about panic attacks. Anything you want to add? Obsessive compulsive disorder, what did you learn about that one?
Real quick before you move on, I have
Sure.
a question about panic attacks. Like, so presenting to the ER, like, is it a little bit different? Because this is obviously someone in primary care. What would you do?
You can use a quick-acting benzodiazepine.
Or do they use like Adhd or?
You could. Pardon?
IV usually, or?
You can do IM. It's water soluble, so it's pretty quickly absorbed. Its onset's a little bit slower than Valium, but it's still pretty quick. Yeah, mostly in those situations they will, and it's rare that they're going to come in with a panic attack because the panic attack will happen to them and then they'll recover. They don't last that long, but they may come into you with complaints of other things, chest pain. Like after my sister has hers, she will say, my chest hurts, And the first time I was with her and it happened, I'm like, wait, you're having a heart attack. She's 12 years younger than I am. I was like, we got to get you. She goes, no, no, no. And I read after that their heart does hurt. It's a physical hurt, but it's not a angina. It's more like a muscle pain. And so she'll complain a lot about that chest pain. So they usually will come in with complaints of other things, and then they're diagnosed as panic. So they usually, I would say, Ryan, they're not going to show up in the ER like this. It'll happen to them like in a movie theater, out in the mall, at home, something along that line. And they won't know what it is at first. Obsessive compulsive disorders. So the goal, I think the goal is interesting. So under the second bullet is, well, first is we want to decrease their frequency and severity. We want to improve their quality of life so that their obsession does not take over or impair or get in the way of their ability to do their job, their social interactions. So a reasonable treatment targets are less than 1 hour a day spent obsessing or performing the compulsive behaviors, no more than mild OCD-related anxiety, the ability to live with it, and no interference or little interference with their daily task of daily living. Okay. First-line treatments are cognitive behavioral therapy and the SSRIs. The other is, you see that tricyclic antidepressant. Do you remember what category they fit in? They're SNRI. So that was the oldest. Those are one of the first groups of antidepressants that were out. Amitriptyline is in that group. Imipramine is or clomipramine is one of the old products also. Anafranil is the trade name of it. So it's around. It certainly could be used. It's just tolerance of side effects is usually a little bit hard. Younger people are probably going to tolerate it fine, but it's an agent that has approval for that. But you'll see the SSRIs are all of that category could be used for OCD. In terms of what to treat, you can treat with cognitive behavioral therapy. You can treat with drug. And again, the same kind of principle applies, is that a drug may help them be more responsive and accepting of the therapy in the beginning, so it's reasonable to do that as well. Start them, and if the behavioral therapy seems to be working, you could always taper them off the drug. But the SSRIs are the first line. Combined is more effective. Using psychotherapy and a drug is more effective for some people. So either one. There isn't anything that says one is the first stop and then the next. So using whatever is going to be most helpful for the patient. If you look down towards the bottom, in terms of timelines, here it's longer. It's 4 to 6 weeks. You look for improvement, but some may not respond until 3 months. So allowing for that longer period of time to judge a response. The top of page 16, the medication or the ADRs are the same. The dosing is about the same as what we see with the antidepressant dosing. Managing it, the same thing, is switch to a different drug if they can't tolerate it. Venlafaxine's also been used. They've used SRIs with antipsychotic. That would be an end therapy. Discontinuing therapy. From what I read, some people never can come off. Some people after a year or two can be tried off with a gradual taper and watching for symptoms to return. So it's the same drugs over and over again. Principles are almost all the same. Side effects are going to be the same. When to switch, length of time is something to note. When to judge effectiveness, how long to keep them on it. For most of them, it's at least a year. Okay. insomnia. So this is a chunk of the handout. So I assume most people have suffered some type of insomnia, so we know. Kristen had insomnia?
I really like sleeping.
So you never had insomnia?
No.
Not really? You're fortunate. Just wait. As you get older, sleep gets more disturbed. Wait till you have kids. Sleep gets disturbed. Kids. Yes. 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 What? Cats. I don't think I've ever slept through the night again after I had a kid. You just get bored. Well, because these women who would say, my baby sleeps 12 hours a night, I put them down at 8 o'clock and they're up at 8. It's like, I want that baby. Dr. Britton is one of these people who only sleeps about 4 or 5 hours a night. And so I should have, because I like 8 to 10 hours. I love my sleep. And he was like a napper. He's very much like Dr. Britton. They both like to graze. They don't eat any one meal. They just kind of graze. Or they're anaconda-like. They eat a huge meal and then they don't eat for 24 hours. Are men not anacondas? They are. They're laughing. I have watched Dr. Britton take down 3,000 or 4,000 calories at one time, and then they just don't eat for a while. What is that? What is that? Anyway, so my son never slept. He wasn't a good sleeper. Oh, it's like, oh. Too much fun to be had, so why sleep? Okay. So insomnia. So the goal of insomnia is to get improved, meaningful sleep. So I know you're going to do the sleep cycle on Friday. Yes. Okay, so I'm just going to do a little bit of background and then move on, just so we can kind of play off of these. So when you have somebody who comes complaining of insomnia, if you take care of, at least in primary care, you will hear it a lot. If you deal with psychiatric patients, you will hear it a lot. So having some familiarity and having an approach will be very helpful. So some is to look at what is brought on the insomnia. Is it a symptom? Are they in pain? Is that why they can't sleep? Is it a chronic pain syndrome that they're dealing with, and so it always disturbs their sleep? If that's the case, then unless you treat the medical disorder, the sleep is never going to be restored. If people have uncontrolled diabetes and they're getting up every 30 minutes to an hour to pee, then their sleep is disturbed, and until you address that, the sleep doesn't get any better. Sleep disorders other than insomnia. So if they have an obstructive sleep disorder, they are very morbidly obese, or they have CHF, and they can't breathe well at night, then don't treat the insomnia, treat the underlying cause, is what it's getting at. Psychiatric disorders and insomnia, it says they're bidirectional. So what it means is one causes the other, and the other aggravates the main cause. So people who are depressed usually don't sleep well. They can have insomnia. They can't get to sleep, or they can't stay asleep, or they can't sleep very long, and then that makes the underlying disease worse. And then the last would be some type of chaotic home. There's no plan for when to go to bed. It's a free for all, and I don't mean a planned free for all. History of childhood traumas, or traumas that are related to that, can then affect adults as well. I don't know. I meant to look this up about military. People have been in not overseas, but have been in situations where they're very unsure of what's going to happen to them, and how that affects their sleep, I'm sure, is would be another reason. Medication. So what drugs can cause it? Well, stimulants can certainly cause. Can you think of some stimulants that we may have talked about or that you know about? Okay, coffee. What else? Amphetamines. So we've talked about some drugs that get metabolized to amphetamines. Remember when we were talking about selegiline? Selegiline is a very activating drug because it gets converted into methamphetamine. What else?
Isn't there a cough syrup? Isn't the dextromethorphan get converted?
Yes, dextromethorphan to a small extent is. What else? Good. Steroids can. They're down. They're not a stimulant though. They're you're ahead of me. Any other stimulants? Okay, so when we get to talking about kids with ADHD, most of those drugs are amphetamine-like, and those can do it. Sympathomimetics, so drugs that you would take, decongestants can do that as well. Okay, so the problem with those is that you can try giving them in the morning, but often they will disrupt the sleep cycle. And, the other drugs we talked about were for weight loss. Early on, remember, amphetamine-like weight loss drugs, Fastin would be one of them. Okay. The other, we've talked about antidepressants, that they also are activating, and so about 20% of people who take antidepressants also will complain of the drug disturbs their sleep. The good thing with that is that usually that attenuates. Usually they grow either tolerant of that or the symptom goes away with using the drug. And here's April's glucocorticoids. They're very psychically active. They can, if you've ever taken a Medrol dose pack, you may have found that you can't sleep when you take them. So often we will try to move those to mornings for a number of reasons, but taking them at night sometimes can interfere with sleep as well. Opioids. So opioids, we think about them being sedating, but they are very damaging to the sleep cycle. And so they can call that sleep fragmentation. So if you've ever taken them for a long period of time, you may have experienced that. Diuretics, so nocturia, having to get up and pee at night. Patients, so anytime I see somebody on a diuretic, they're complaining about getting up at night, it's like, when are you taking it? So usually we want to take them in the morning, but sometimes they're on twice a day diuretics. So usually we would prefer they not take them past like 2 o'clock in the afternoon. Now if they go to bed at 5, that won't help, but for most people that will do it. Look at perpetuating factors. Anytime I'm having to deal with patients who are complaining about insomnia, one of the things I'm asking is just about this, is what's your sleep hygiene like? Because most people who haven't, or I shouldn't say most, but many people who you will see who have insomnia also have terrible routine for bedtime. So let's kind of look at these. So determine consistency of bed. The older you get, the more this will affect. If you've ever raised a kid, the one thing you learn is you put them to bed at the same time every night. Yet otherwise, they have no idea, the body has no idea of when to put itself to sleep. So regular timing of bed and when you get up is better. The body likes a schedule, likes to know what's coming. Asking the people if they're really sleepy. Sometimes people think, I ought to go to bed at 10 o'clock. Well, are you sleeping? Nope, I don't go to sleep till midnight. Well, then why do you go to bed? You'll find it in older people. They're like, I want to go to bed at 10:30. Are you sleeping? Nope. So some of it is aligning what is reasonable with what their body wants to do, what their expectations are versus what really happens. Napping and dozing during the day. This is a big one. I love Sunday afternoon naps. I cannot do them anymore because they kill my Sunday night. I just can't do it. I used to be able to sleep all Sunday afternoon and then get up, do a few things, and go back to bed and love it. Can't do it. Level of anxiety regarding sleeplessness. People who are chronically have insomnia or cannot stay asleep or get to sleep and develop a phobia about it. And they get very anxious about the fact that if I go to sleep, I'm going to wake up and I'm not going to be able to get back to sleep. Clock watching. If you're clock watching in bed, you need to just get up and do something. If I can't fall asleep when I go to bed, I just get up and do something like fold clothes. I don't know. Asking about our nocturnal environmental disturbances. So are children getting into the bed? Is it a family bed? Are the animals getting in the bed? Are there electronic devices in the room that are TVs blaring? So if the environment isn't conducive to sleep, that certainly can add. And then expectations about sleeping. You'll hear it a lot in older people because they may have been used to sleeping 7 or 8 hours, and now they've gotten to where they only sleep 4 or 5. Well, can you get up and function? Yep. Okay. Don't need it. Don't worry about it. So sleep hygiene. These are the basic rules for a good night's sleep. Sleep only as much as you need to feel rested, and then get out of bed. Okay. Keep a regular sleep schedule. Go to bed about the same time every night and get up about the same time every day. I'm a night owl. I love to me, 1 and 2 and 3 o'clock in the morning are golden. Love them.
Yeah, those are the witching hours.
Love them. I can't live like that, though. I can't do my 8 hours of sleep in between 3 and 7 o'clock in the morning. My sister and I are all night owls. So when I go home, we have the best time from about midnight to about 3 o'clock. We watch we post all the YouTubes that we think are fun, and we dance, and we just have a great time. But I can't live like that. When I get up on, when I get to Friday and Saturday night, I'm so happy because I can stay up late. But then I pay for it because when it comes to Monday, I am dragged. It's why I never have Monday at 8 o'clock. Never. Because I couldn't talk to you. So anyway, important to have that regular schedule. Don't try to sleep unless you feel sleepy. Exercise regularly, preferably 4 or 5 hours before bedtime. Any of you exercise right before bedtime?
Yes.
Yes, I do. Can you go to sleep?
Yeah.
You can't? Who else? I can't either.
At all.
Actually,
I used to go exercise at 9 o'clock every night, but then I get wide awake. I can't.
I did that in college when I stayed up till 2.
Yeah, when you can stay up till 2 or 3. You exhaust yourself. I can't. It's activating to me. I want to get up. Avoiding caffeine after lunch. That is a lie. There is no way. Okay. Okay, but it's one of the rules. Alcohol really disturbs the sleep cycle. So people always ask about that, about alcohol content or what they're drinking before they go to bed. Sometimes people will use alcohol to put themselves to sleep, but they will not stay asleep. It ruins that cycle, that 4th cycle, or level 4. Do not go to bed hungry. Some of your patients, you're going to go, I'm never telling them that, because they will overeat. So I grew up with mostly sisters. I had one brother, but I didn't pay much attention to him because he was just an aggravating little. He cut all the, he tortured us. He was younger, but he just did everything to get us. He cut all the fingers off my dolls. He would set our dolls' hair on fire. He would put little firecrackers in them and blow them up. You know, he was just anything to aggravate us.
You set his hair on fire?
I did not.
That's how you take care of that.
No, what I did is I'd dress him up like a girl and make him ride his bike up and down the... Yeah. We lived in the country, though, so no one ever really saw him. So when Cameron got to be about 16, his bedroom was right above ours. So at night, about 2 o'clock in the morning, we would hear him walking around. And then we'd hear him come down the stairs. He'd go get in the kitchen. He would pour a big bowl of cereal, eat it, and then go back to bed. Do you all do that? Is that normal?
Oh, nighttime cereal.
You used to do that? Fong, did you do that? No. Ryan, did you do that? No. You could sleep all night and have to get up and eat? Okay. Make the bedroom environment conducive to sleep. So asking about that. How many of y'all do this? Avoid prolonged use of light-emitting screens before bedtime. I read my books off my phone. Deal with your worries before bedtime. Okay. What?
The amber light, like on the phone, they have a night shift mode.
Oh, no, listen. No, I didn't know this. Really?
On iPhone, it has under settings, under brightness, display brightness, there's a night shift mode, and it tints your screen amber, so it blocks the blue light. And then on your
Computers have
laptop,
it too.
there's something called Flux, and you can download it. And so if you're working late at night, it blocks
Really?
the blue light.
Yeah.
Really?
I have it on right now.
Really?
Yeah.
Or you wanted to go to sleep?
It gives me headaches.
Oh, really? The amber? The blue light?
Yeah.
Okay, I didn't know that, thank you. Okay, medications to treat insomnia. So there's two big groups. There's the benzodiazepines and there's the non-benzodiazepines. Okay, they both act on GABA receptors. There are some that are, I would consider those are ones that most people are going to go to. Then there's the orexin receptor antagonist, that's Belsomra. And then the melatonin receptor agonist is Rosarim. How do you say it? Rosarim.
Yeah.
Then there is a new one that's on the market that I've got it later in your handout that is in that same class. The tricyclic antidepressants have been used for a long time for their sleep. So amitriptyline, this one, doxepin, is in that same group. It has a FDA approval for it. Other like trazodone, another tetracyclic antidepressant, antihistamine. So Benadryl, people buy Benadryl over the counter and use it. And also melatonin is been used. So which agent do you choose? So you're going to look at the type of insomnia the person has. Do they have sleep latency, like they can't get to sleep, but once they get to sleep, they can stay asleep? Or do you have people who can get to sleep, but they can't stay asleep? They wake up in the middle of the night. You may have people who have both. So you're going to match your drug towards this. Some of the drugs are very rapid in onset, so you use those to help people get to sleep. There are some, and a lot of these will be made into extended release products. So those often will help people go to sleep and stay asleep. Then there are other products that are intended for people who only wake up in the middle of the night. So Ambien has a sublingual that you can take in the middle of the night. When I went to China, that's what I did, because about 2 o'clock in the morning I was wide awake and I never could get back to sleep. So I did use those. Sublinguals are very effective. But they require that you have at least 4 hours ability to sleep at least 4 hours. So all of these, so look at what type of problem the person's having. The other is think about those other things. Is there an underlying problem that is causing the insomnia? Direct your efforts towards that. Or is there good sleep hygiene and advising? That I can guarantee you most people are going to have problems with sleep hygiene, so reviewing that with them. Okay. So for people who have sleep onset insomnia, a short acting. So examples of short acting would be the first two are non-benzodiazepine, Sonata and Ambien. Tricyclic is a very short acting, a rapid acting benzodiazepine. Look at the names they give them, Halcyon. Okay, so marketing people are usually non-medical people. They're marketed for a reason. Sonata, Ambien. So they're those things to remind you of sleep. Sleep maintenance insomnia. So usually those are longer acting. So you'd use a longer acting benzodiazepine, which would be like temazepam or flurazepam or quazepam. Those are all very long acting. The Ambien has an extended release, Lunesta. That's the little moth-like one that floats. You like that one? Those are longer acting, so they'll maintain sleep. On page 19, the awakening of the middle of the night are talked about there with Ambien and Sonata. Both have a short, rapid acting. Thing to keep in mind is at least 4 hours. So if they've got to get up at 6 and they're awake at 4, that isn't the drug to go to. So some things to keep in mind are there in the middle of the page. Most of these will increase congenital defects, so don't give them to pregnant women. And pregnant women always have problems sleeping, especially the longer they get into their pregnancy. Hydroxyzine could be used in that case. Alcohol consumption. Sedatives and hypnotics don't mix. They can cause significant respiratory depression and overdose. These drugs are cleared by usually the liver or the kidney. So people who have decreased liver function or renal function, be very careful with these drugs because it'll just extend their duration of action. Pulmonary disease or sleep apnea will make it worse. Respiratory depression would be the risk there. An interesting one you may not have thought about, but are nighttime decision makers. So if you're a clinician on call, you don't want to take this. Okay? If you are a single parent with kids that you are responsible for, you don't want to take it. FAA. Do you know about how long they have to not have had one before they fly? Would you ask him? Oh, that would be great. And then older adults. So the older they get, you know, their kidneys and their liver may not be acting as well, but over the age of 75, be careful. Again, they are going to complain to you because it is a common problem in older people is that they just don't sleep well. They're nappers. So, and they'll get into a bad cycle of they'll take an afternoon nap and then they can't get to sleep. So asking about those types of activities is important. Okay, the benzodiazepines. Let's talk about the different classes. So these reduce the time to get to sleep by about 10 minutes. So they're rapid. Like Halcyon, very quick. They prolong stage 2. They prolong total sleep time. So people like these. The most common ones, almost all of them have been used, but these are common: Halcyon, Prosom, Ativan, Referral, Dalmane, Doral. Dalmane and Referral are much older products. I don't know how much they're used anymore. They're very long-acting, so they have a lot of hangover effect for the next day. So sometimes it's hard for people to function the next day after they've used them because of how long of action. So I'd say they are not, I can't imagine that they're used as much as they were in the past because we have better drugs. Page 20, so primary difference is their duration of action with the benzodiazepines. So again, Halcyon, Triazolam, very short acting. It's about the only thing it's used for is insomnia. The 3 or 4 there in the middle are intermediate acting. So for people who need sleep maintenance, these would be good drugs to look at. Florazepam and Quazepam, they are very long acting. I don't know, I wouldn't look at them early on. Diazepam, very long acting, but but it accumulates. That's the problem with Valium and Librium. Very, very long acting. Takes a long time to clear them. Yeah.
He answered 8 to 12 hours.
8 to 12 before the end. That's for, did he say which ones?
No, I don't think he doesn't.
Okay, so
And that could be the military. I don't know if that's FAA.
okay.
They sometimes have different rules.
Okay.
He said, 8 to 12 hours depending on the pill.
Okay. That would fit for most of them, especially the rapid acting ones. Okay, thanks. Okay, so those are the benzodiazepines. The non-benzodiazepines, and these are the ones that are on the TV all the time. Sonata, Ambien. Ambien's probably the first in that group. It's got a lot of different dosage forms, used quite a bit. Lunesta is the other one. So these have different dosage forms that using whether, if you can't get to sleep quickly, then they've got rapid acting, they've got extended acting, and then they've got the ones that can be used in the middle of the night. So this class is very good in terms of different products to match what the person's having trouble with. Let me have you go down to about the second bullet from the bottom. Most of the side effects are headache, overly drowsy, or dizziness. In the older people, be careful because they can lead to falls. A couple of years ago, the FDA came out and said probably need to use lower doses in women, and that actually would probably go for men as well. The longer they were in use, then they came out with another safety announcement, and that was at the bottom. Don't drive or engage in other activities that require complete mental alertness the day after taking Ambien extended release. Because levels can stay high enough to impair them.
Dr. Patsy?
Yes?
Insurance companies are now taking that FDA from January 2013 to heart, we had a lot of older patients who are only like allowed 15 pills in a 30-day period.
Okay.
And it has to be like the lowest strength. They started not approving the higher
For 30
strength
days.
Ambiens. Yeah, for every day.
Okay, thanks. Very good.
Also, no, Ambien does not make you racist. Did y'all hear
Yeah.
that?
What?
Rosie O'Donnell.
Oh, it was Roseanne.
Roseanne.
Yeah.
It may not make you a racist, but well, I'll get to that. She is a very good example, and I'll give you some others of people I've seen. Lunesta is very long acting, so it's 5 to 7 hours. So people, it's very good if you've got somebody who cannot get to sleep and can't stay asleep. Think about that one. Safety communication with Lunesta. On the higher doses, impairment of driving skills, memory, and coordination lasting more than 11 hours without subjective awareness. Okay. This is very common with these drugs. I've seen people come in that you thought it was an acute dementia. They don't know who they are, where they are. They come in with symptoms that are similar to TIA, stroke. I've seen them worked up for that, and it's actually the holdover of drugs, especially in older, maybe even 50 and 60-year-olds. The other is the downside is when you take these drugs away, they often have rebound insomnia. So you have to do a lot of preparation when you are going to take them off and taper them, or have expectations is that you're not going to sleep as well, but you will revert back. So these are almost always intended for short term. There's a couple that have approval for long-term chronic use, but for the most part, we want to move people back to not dependent on a drug to get to sleep or stay asleep. If you look down towards the latter part of that page 21, complex sleep-related disorders. If you look under it says in one study, Ambien accounted for 12% of all emergency visits for adverse drug events related to a psychiatric medication. More common in those over 65. Other considerations: habit forming, the rebound insomnia. The very bottom of that page, I want to go over these. So other sleep-related behaviors, I have seen these happen to people. Sleepwalking, driving and making phone calls, eating, having sex, and not fully awake. Having amnesia, aggressive behavior, severe allergic reactions. So I had a young couple that was referred, the woman was referred because she had diabetes. She was a young gal, probably in her maybe early 30s. Her husband came with her, and one of the things we were talking about was eating at night because her sugars were just out of sight in the morning. So one of the things I was like, do you get up and eat at night? A lot of people don't remember that they eat at night. I had one patient's family who put a camera over the refrigerator to show this person that they did get up in the middle of the night and eat because they denied it all the time. So they snitched. But as we were talking about this, he said, she does the darndest things in the middle of the night. He said she gets up and she cleans the house, she does the laundry, and she washes the dishes and has no recollection. And he said, and when she gets up in the morning, she's like, who did that? I have just seen so many bizarre things of people being somewhere where they don't know how they got there, and these very weird sleep-related behaviors. So I actually can see where Roseanne got herself in trouble because of these drugs. Now, her basic personality is her basic personality, but these drugs can bring out aggressiveness and disinhibition that I think could allow her to go on a rant. So I do believe there's a part of a truth there. The other truth is that she's Roseanne. But disinhibition and aggressive behaviors on top, I do believe it could have brought out things that she rather would not have come out in the light of day. So that's my opinion, though. Top of page 32, I don't believe it can make you a racist, but I think if you have bad if you have thoughts that aren't socially acceptable, they could certainly uncover you. Older adults, keep this in mind: cognitive impairment, weird acting out behaviors, dementia-like behaviors, risk of falls. Also keep that in mind for them getting up in the middle of the night. Okay. Yes.
So what if you're like prescribed a stimulant like Adderall or something, and then you have insomnia? Can you do like side effects?
Well, with Adderall, there's a lot we can do with the dosage form. When we give it to you, there's all kinds of different release forms, so we can have some that release right away and then release slowly over the next 8 to 12 hours. So we can do a lot with the dosage form. But I wouldn't use. I'd do that before I did this. I wouldn't mix the two. Okay. The next two agents, the melatonin agonist and the Balsamra, these are agents that work on different receptor types. The melatonin agonist, I don't know what to say about that, except it would be an alternative. In Europe, they actually didn't approve it because they did not feel it was effective. So it's going to be a much less effective drug than the benzodiazepines or non-benzodiazepines. But for sleep maintenance, they may be a reasonable option. The same with the Balsamra. This one works on a different receptor. It is a controlled substance because of its abuse potential. It is a drug that has more drug interactions, so you'll see the 3A4 inhibitors is a potential for toxicity. They can cause impairments, cognitive impairments, driving impairment. So this is one that would be down the line, and probably only if you could not use the other agents. Very long half-life, so it's going to be a problem for next day. Let me just point out some things on page 24 since we're at the end. Antidepressants I talked about, they are something to consider. And it also, if you're dealing with insomnia and you have to use an antidepressant, that you might look at some of the more sedating ones and take care of two things at one time. Often as the depression resolves or responds to the antidepressant, their sleep cycle will become more normal. Amitriptyline has certainly been used. We use it, so if we're going to use it for other things other than depression, we'll often give it at bedtime and take advantage of its sedating properties. When we talk about diabetic neuropathy, it's a very effective drug for that. We give it at bedtime because of its sedation. Trazodone is another type of antidepressant that is not very effective as an antidepressant. We use it primarily for sleep now. Diphenhydramine, very effective, but be careful in older patients about them using that. This is one they can self-medicate with. It'll put you to sleep, but it also gives you that hangover period in the morning. Herbal products, lots of them out there. I listed a few of them: valerian, chamomile, the tea, kava, and wuling. There is no data that says they're effective. Be very careful with valerian. Valerian root are popular, but they have been fraught with contaminants and side effects due to the contamination of those products. So if people are on valerian, I really try to talk them off of it to something else. Chamomile, I don't think it matters. If you enjoy it and you think it helps, then there's no hurt. Melatonin is something you can buy over the counter. It probably is helpful in people who are going to be moving through time zones. So it may be one that people take and help to reset themselves in another time zone. It's a relatively low-risk drug, over-the-counter, so patients can use it on a PRN basis or short-term for sleep disturbance. Alcohol, commonly used, not a good idea because of its impact on sleep cycle. So failure to respond. If a patient does not respond, then look at, have you matched the drug up to the problem they're having? Are they taking it appropriately? Do they wait too long? Do they lay in bed for an hour and then decide to take it? So matching it up that way. Or they're taking it too far in advance and then falling asleep at the wrong time. Moving them to another drug is important, is an option. If they're having that daytime sedation, look at a shorter acting drug. Constantly moving to them to the point where they will no longer be on it. Therapy for sleep disorders. I would really talk to Jamie Massengill about what options do you have for people who have severe disorders. Because when you get out there, it's just, especially with psych folks, it's just so common. There is a whole nother community of people who are awake all night long. You know, they sleep until noon or 4 o'clock, and then they get up and they're up all night. They don't work, and they're, you know, it's okay. I'm not saying anything bad about them, but they often will bump up in terms of being able to get to appointments, because they don't sleep in a normal pattern. So they also, their engagement with people, so their engagement, social engagements may be all computer, because there's nobody up at that time of the night for them to interact with. So it does bring some things that play into their disease and their ability to cope. Tapering medications, these drugs need to be tapered. You really need to set them up. There will be lots of anxiety. If they've been on it for a long period of time, a slow taper would be reasonable. Reasons for referral would be is if you suspect that there is another problem that is causing, that's the underlying cause that hasn't been diagnosed or worked up or treated appropriately, and the other is that they're not responding to effective treatments. So I would ask Massengill about where do you send them? Okay, questions? Sorry to keep you a little bit. All right, I'll talk to Dr. Britton about, he mentioned this about the antidepressants so that you have some sense of what we're going to focus on for those off the other handout. Because, let's see, I don't think I see you again until your test, right? Right. Okay. All right. See you in musculoskeletal.
Happy birthday.